But again, it is targeting the pump, the proton pump, and that results in a decrease in acid production. This particular drug is best given on an empty stomach. The downside is, at least from a nursing standpoint and a prescriber's standpoint, we have to tell patients that there are multiple drug interactions with the proton pump inhibitors. The 4 that you see here are quite common: omeprazole, esomeprazole, lansoprazole, and pantoprazole. And we have a short movie that you can watch if you're interested in just knowing a little bit more about these drugs. But the proton pump inhibitors are top of the line in terms of controlling acid. These are typically drugs that are started in patients who are at risk for severe complications, increased acidity. Typically, they are prescribed after a patient has been assessed by upper endoscopy. We have to be careful when we're using all of these drugs in that we're not treating or covering up a condition that may be more severe, like a significant gastric erosion, an ulcer, a gastric or duodenal ulcer, severe gastroesophageal reflux, and esophagitis. So that is data that we like to obtain before we start this type of a medication if possible, especially if treatment is expected to be prolonged. And so this slide is a cute cartoon which reminds us some of the more severe conditions that we can treat. And gastric ulcer shown here, duodenal ulcer, esophagitis. So getting Prilosec for the treatment of these drugs are very useful and will control symptoms even in some of the most severe cases, and control it to the point that we can resolve the symptoms and heal the gastric mucosa. Now you'll notice here the mention of Helicobacter pylori, which we spoke about the other day. Helicobacter pylori, when it is present in patients with these high acid conditions, can result in more severe symptoms and complications. So if we diagnose that, and we can diagnose that directly by biopsy or urease breath test or an antibody test, when that is determined, we will treat the helicobacteria in order to resolve the infection, in addition to treating the patient with a drug like a proton pump inhibitor, and oftentimes even with a mucosal protectant. So it's not unusual for these patients to be on what we would call a GI cocktail, more than one drug, to resolve these patients' symptoms and treat them. The second class of drug is one pharmacologically that is important for these patients, although perhaps used to a lesser extent than the other 3 that we've talked about, and that is the prokinetic agents. Now, prokinetic agents, as the term suggests, we think about the word kinetic. Kinetic, we think of movement, motion, activity, and pro, to promote. So prokinetic agents are going to stimulate gastric motility. And that provides us with additional effects of the drug that are helpful in the treatment of these patients. Number 1, it increases lower esophageal sphincter pressure. And we talked about that it's important in reducing gastric reflux, acid reflux. Also, it increases gastric contractility. In other words, the mixing, the churning, and peristalsis of the stomach. That increases the rate of gastric emptying, and that can be a favorable effect in these patients. It also serves by blocking dopamine, and by blocking dopamine, it serves as an effective antiemetic. And we'll talk a little bit more about this class of drugs later and their role in controlling emesis. We need to remember that this drug should be given 30 minutes before meals 30 minutes before meals. And the most common, perhaps, is this drug, which is metoclopramide or Reglan. Metoclopramide or Reglan. And here we have a slide to remind you of some of the side effects of Reglan and its ability to treat not only GERD, but also delayed gastric emptying, which you see here, delayed gastric emptying. Okay, and what are the side effects? What are the side effects? What do patients need to watch out for? Sedation, insomnia. So either patients may be too sleepy. That may be a side effect for one patient. Another patient may experience insomnia, the inability to go to sleep, or intermittent waking, diarrhea, or the opposite, constipation. So, in other words, this drug can affect patients differently, and that depends on the response of the patient to the drug, and in some ways, it's sometimes the dose that's used for the patient. GI prostaglandins, a different class of drugs that are useful. They inhibit both gastric acid and pepsin, and we haven't talked a lot in this presentation about pepsin, but pepsin has a role in increasing the effects of gastric acid. So by inhibiting both gastric acid and pepsin, gastric acid and pepsin, then we gain an additional benefit in terms of protecting and reducing the symptoms in these patients. Now, this can protect the gastric, the stomach, as well as the duodenal lining. The adverse effects are not unlike the other medications that we saw. Some degree of abdominal or GI upset, in this case diarrhea and abdominal pain. We have to remember that this drug should not be used in pregnancy. And most of these drugs that are contraindicated in pregnancy can have effects on the fetus, developmental effects, and growth effects, and in some cases congenital effects. So for this drug in particular, we're not going to use during pregnancy. The drug has to be administered more than once a day, so taken usually 4 times a day and taken with food. Perhaps the most common, the most famous drug in this group is misoprostol. Looking at our next drug as a classification group, so we're going to take this group and talk about it as a class. It is one of the drugs that we already spoke about is included in this class. It's very effective as this group as a whole as an antiemetic, and the one that we mentioned already is Reglan or metoclopramide, which I'll highlight here, and perhaps the most common. But other drugs that we'll include in this class are the phenothiazines and the butyrophenones. Their action is to inhibit dopamine receptors that are part of the vomiting center. So for that reason, these drugs are very effective in limiting emesis or reducing emesis. And that's important in some patients. In particular, in the hospital, patients that are either pre-surgical or post-surgical experience a significant amount of nausea from the drugs that we give during anesthesia, including some of the inhalants that we use. Surgery in particular, radiation therapy, chemotherapy you see as part of this group, all of these patients may have emesis that is relatively difficult to control with the use of drugs that we use as an outpatient. So there are some side effects, but the use of these drugs for emesis in patients that are hard to control really can't be understated. Serotonin antagonists. So serotonin is a drug that we're very familiar with. When you think of serotonin, you think of a drug that's used in mood elevation, serotonin. Serotonin is an important neurotransmitter, so that's where we hear about it the most. But in terms of its use here, this lecture is GI pharmacology. This particular drug is also very effective at preventing nausea. And so this drug is useful in the treatment of chemotherapy patients, radiation patients, cancer patients. In general, some of the side effects that they experience from multi-drug combinations. How does it do it? What's the action? Well, its action is to block the serotonin receptors located in the medulla, which affect the vomiting center. There are some side effects of the drug, and they are listed here. Headache, diarrhea, constipation, sedation, I've highlighted because sedation is a relatively common complaint with the use of these drugs. The anticholinergic drugs. So when we think of anticholinergic drugs, this is important. These drugs are important. And you will be asked about the anticholinergic agents as well as drugs that are used for other treatments that have anticholinergic side effects. So this is particularly high yield in terms of need to know for standardized tests like NCLEX, like PANCE, like USMLE, like the HESI exit exam. So we have to be very familiar with these anticholinergic side effects, and that helps us understand this class of drugs. Now, as a GI agent, this drug is particularly useful in the treatment of nausea. Some of these drugs are used in the treatment of motion sickness, those side effects that come from vertigo. They can be used in the treatment of pregnant patients, in recalcitrant emesis. The way that they work, they counterbalance the excessive amounts of acetylcholine, which can cause motion sickness or that spinning side effect, dizziness, and subsequent nausea and vomiting. There are some adverse side effects noted with these drugs, and we'll talk about those when we get to some of the other drug classes. But most notable, the sedative effects of these drugs, some of the effects that come from the anticholinergic, like dry mouth, and some of these other general side effects. But they're notable, and patients will complain, and it can result in non-compliance. So we have to be mindful of drugs that have anticholinergic side effects, and we'll talk about them when we get to mental health, because this is a predominant side effect or dominant side effect in a number of the antipsychotic medications and some of the other drugs that we use to treat mental illness. Okay, corticosteroids. So corticosteroids are a high yield area of testing in pharmacology. There are many corticosteroids, and in fact, we talk about corticosteroids in terms of potency. Perhaps the most common in this class that we are familiar with is, which I'll write here, hydrocortisone. Hydrocortisone, okay. So found in most drug stores over the counter in formulations of 1%, often next to cortisone. So formulations. And so these are drugs that are commonly used. Did I leave out my O here? Cortisone that can be used for topical inflammatory skin conditions, treatment of mild poison ivy, eczema, and other skin conditions, skin irritation. Not meant for long-term use, and in fact, using long-term use is discouraged because it can result in thinning of the skin, and there is some systemic absorption when used over a prolonged period of time. So these are some common formulations, and these are mild or low potency steroids. But we have other steroids not listed here, but I'll mention one that's relatively common that's given orally, prednisone. So oral prednisone, very common. So this is typically given in a higher dose on day 1 and day 2, which is very quickly tapered and works for example, severe poison ivy, bronchitis, respiratory treatments, concurrently with other medications that might be used to give that added effect of resolving the acute inflammatory condition that the patient has. So that's prednisone, and including steroids that we use intravenously for the treatment of intracranial pressure, for even now in systemic inflammatory conditions, a prominent drug that we now know improves outcomes in COVID viral infection. So we've got some of these listed here. Solumedrol would be included, Decadron. So these drugs a little bit higher in terms of their potency, and so you're expected to be knowledgeable of the most common steroids and an idea of their potency, what they should be used for. We know many of the effects of steroids, but we'll say that the action or the mechanism of action is unknown. And you'll see that, you see that here on this slide, and you'll see this in many textbooks. But a very good drug used in moderation. So in combination with antiemetics, back to our discussion on GI protocols with corticosteroids, this drug is a pretty good antiemetic, very good for nausea and vomiting, and can even be used alone. There are some serious effects that we have to be aware of that we certainly will be asked about on the NCLEX, and that is notable, we'll say immune suppression. So it affects the immune system. It can cause bone demineralization, adrenal suppression, and significant local effects from long-term use. So the use of steroids, as I said, the idea not to overuse, but to use these drugs when needed. They may even be needed in autoimmune conditions, sarcoidosis. There's a number of pathologies that we can think of where we use corticosteroids for long-term treatment. COPD, asthmatics, since this drug can be given as an inhaler in addition to the other routes of administration. So it's not unusual. Pulmicort is a very common inhaled steroid, but steroids in most cases are not first line because we know about the side effects of these drugs. I'm also going to say hyperglycemia. So we use these drugs with some caution in diabetics because this is a side effect, hyperglycemia. Okay, so this is a steroid class of drugs, high yield for these types of examinations. Not only routes of administration, potency, as well as common and serious adverse side effects. And we'll pause here, and then when we come back, we'll continue.